Hello and welcome to Westwind, an audio podcast about cancer, technology in medicine, and policy issues. I'm host and medical oncologist Dr. Jack West from the City of Hope Comprehensive Cancer Center in the Los Angeles area. You can find Westwind material at BeaconMedIC, one word.com, at iTunes, or just about anywhere you get podcast content. I would just ask that you show your interest and support by subscribing, commenting, sharing by telling friends and colleagues in person and on social media, and rating it however you feel is appropriate. You can also share your ideas and opinions by emailing us at westwindpodcast@gmail.com. We're continuing our discussion with Dr. David Palma, radiation oncologist in London, Ontario, in this new episode. Are there issues with radiation oncology in Canada that are unique to Canada versus the way it's done in the US? I would imagine that if access to radiation oncology facilities is anything like PET-CT or MRI, the geographic distribution of radiation oncology centers is a real problem for a decentralized population in Canada. How does it work, and is it a real challenge with wait times getting in and just managing people who are on several weeks of treatment?
Yeah, so we have some definite challenges, and then we have some definite advantages. The biggest challenge, as you noted, is the geographic dispersal. Although most of Canada does live along the border with the US, we like to be close to you guys, but there is a lot of dispersal. And our catchment area, so I live in a city of about 400,000 people, but our catchment area is a group of about 1.5 million people, and some of those can live about 3 hours away. There are some even more remote locations that are 8 to 10 hours away from some different cancer centers. And we know that radiation utilization in those places is lower. So how do we mitigate that as best we can? We do a lot of telemedicine. I would say about 10% of my patient contact is via telemedicine. But to deliver radiation, you have to deliver it in person. So what all of our cancer centers have is a subsidized place where patients can stay, and they can stay for the full 6 or 7 weeks of radiation. Sometimes what we do is we try to build smaller radiation centers in these remote locations. So that is a big challenge for sure. But that can be an advantage too, because even though we're in a city of 400,000 people, we are an extremely high volume center. For head and neck, we see about 400 new head and neck cases a year, which is very high. And lung cancer surgery, Jack, which you know very well, a U.S. center is considered high volume. If that center does 40 lung cancer resections a year, we do 200, so our numbers are big.
Yeah.
The other disadvantage can be wait times. Because there's only one center, sometimes the wait times can be longer. And so the government tracks it very carefully. And what we need to do is we need to have a time from referral to first visit of less than 2 weeks. And we hit that almost all the time. And from when a patient is ready to treat with radiation, treatment also has to be instituted within 2 weeks. And we also hit that about 90% of the time, which is pretty good, because the quickest you could possibly do it is really maybe 3 or 4 days for a complex radiation plan, except for some very extreme cases where people have their own dedicated, highly specialized units in the US. So we try to mitigate that as best we can. I talked earlier about how my wife is a family doctor. Those are really where the challenges are. For a family doctor in a Canadian system ordering an MRI, it can take a lot longer than in the US, where I suspect you just go get it the next day or a couple of days later.
Does having the system be more centralized and potentially patients staying there make it easier to deliver concurrent chemoradiation in settings like head and neck or lung?
Oh, absolutely. So I would say every major Canadian center, we have a chemo suite here. We have our medical oncologists on site. So in our lung team, we have maybe 6 or 7 radiation oncologists and the same number of medical oncologists. And they'll go from the chemo suite down to the radiation department. Chemo would be in the morning, and then go down to get their radiation right after. So that is a big advantage for us. We don't have medical oncologists at a different hospital. Some centers in Canada do have that, but it wouldn't be as dispersed as I think it would be in the US. I didn't realize that was a challenge for you guys, Jack.
It can be. I mean, it's not uncommon for patients to potentially be receiving their chemo and their radiation in facilities that are quite a distance away, and to try to coordinate those to get weekly therapy but be 15 or 20 miles from each other is not trivial.
Yeah, and I could see, one of the nice things about our system of being in the same center is that when there's an issue that arises, you have both modalities on site. So if a patient, let's say a head and neck patient of mine, comes to my review clinic with febrile neutropenia, I'll get on the phone with a medical oncologist and we'll figure out who's going to admit them and how that's going to be managed. And we have also the training staff. We have the medical oncology fellows, the radiation oncology fellows. So it does make that part of it a bit easier, I guess.
Yeah. One of the issues that has long been an interest for you, in fact, I think a guiding focus of your career path, has been stereotactic body radiation therapy, which has evolved incredibly over the last several years or decade or more. What do you see as the role for SBRT today in the setting of lung cancer? Is it in medically inoperable patients primarily, or does it yet have a place alongside surgery as an alternative for candidates for surgery?
I would place it in the role of the medically inoperable patient or the patient who's refusing surgery. I know that we do have debates at conferences about whether stereotactic radiation should be replacing surgery as a treatment of choice. And my own personal belief, and I think this is borne out very well by the evidence, is that if you are a patient with access to high volume surgical services, if you can go and have your lung cancer removed at a center of expertise where we know the mortality rate from that surgery is going to be extremely low, then you should go and have that cancer removed if you want the best oncologic outcomes and if it can be done safely. Because we know that with surgical resection, the tumor is out. You're not going to get a local recurrence after a lobectomy because the lobe is out and it's in a bucket in pathology. So there's not going to be a recurrence there. With stereotactic radiation, we're only treating a smaller area and we don't always sterilize the tumor. And you and I have had a discussion about this, Jack, on a podcast for JAMA Oncology. And surgery also does offer the opportunity to sample the lymph nodes. So I do think that as much as we like to advocate for our specialty, we need to wait for these randomized trials. And Drew Mokonaki is leading a big one at the VA called Valor, which is comparing surgery and stereotactic radiation. I think the way that stereotactic radiation would come to be preferred is if the toxicity of surgery is more than we think, because stereotactic radiation, on balance, is much less morbid than a surgical resection, although we do have complications. But nonetheless, the disadvantage of the stereotactic radiation is I think oncologically the control isn't as good, but the benefit is the reduced toxicity.
Yes. At the same time, thoracic surgery isn't what it once was either, and it's much more common, and many patients are good candidates for thoracoscopic surgery, which is just a much less morbid process than a big thoracotomy.
Absolutely. And I think one thing that happens with both our specialties is that we're comparing our current technology against another specialty's publications that report on patients from 10 or 15 years ago.
Right.
So if I publish my stereotactic results, they say, okay, look at how the surgeons did in their last paper, but these people were treated in 2005, before people were doing VADs, before we had PET staging. And I think we just ran into this in the opposite way with this orator trial in head and neck cancer, where the surgeons had the new technology, the transoral robotic surgery, and we're comparing to the radiation patients of the past. And when we did the randomized trial, that hypothesis of TORS being better didn't pan out.
Great points. Let's turn to oligometastatic disease, where you've been one of the people who has been very influential, leading some of the key trials and speaking extensively on it. And I know you've heard and thought about some of the criticisms and limitations. Let's just start with what you think of as oligometastatic disease in terms of the extent of disease and the number of sites, because you've done trials and the radiation oncology field has done trials with varied definitions of up to 3, 5, or 6, and now are running SABR-COMET 10, which is for 4 to 10. So how do you frame the concept of oligometastatic and the realistic goals or expectations of radiation here?
I would define oligometastatic as 1 to 3. That's where the best evidence lies. 1 to 3 metastatic lesions. You have to temper that a little bit by whether or not the primary tumor is controlled or not, because that in itself is a worse prognosis if the tumor is still in place and has not been treated. The best evidence, though, by far is 1 to 3. When you get into a situation of 4 or 5, some of those people have been included on some of those studies, but the numbers are extremely small. Beyond that is where our specialty has really run farther than the evidence can support. And we do have centers treating 20 brain lesions with stereotactic radiation. The justification in that setting is that they say, well, that's preferable to whole brain radiation. And that might be true. It might be true, but it might not. And we don't have trials in that space to tell us that as of yet. If you think back to the situation of a single brain metastasis, we know that stereotactic radiation improves survival compared to whole brain, or surgery improves survival compared to whole brain. But beyond that, we don't have randomized evidence. And it's a struggle for our specialty, just as surgeons struggle, is this tension between pushing technology, but also not letting things go too far before you get supporting randomized evidence. So with the issue of SABR-COMET 10 treating 4 or more, that should be done, in my opinion, best on a clinical trial. And I wouldn't say that 7 is oligometastatic. I think the paradigm of why we're using radiation in somebody with 7 metastases is a bit different than somebody with 1. I think when you have 1 metastasis, there's a plausible chance of cure, meaning 5 years, 10 years survival without cancer recurrence. That's been shown. And although the majority of patients who have oligomets will develop more mets, there's a minority with 1 or maybe 2, maybe 3 who will not have the cancer come back. In SABR-COMET 10, with 4 to 10 lesions, we're not trying necessarily to cure, to eradicate all types of disease, although if we do, that would be fantastic. What we're doing in that scenario is lowering the radiation dose, giving a more modest dose of SABR, seeing if we can safely control these lesions for a period of time. But the expectation is that other lesions will pop up down the road. We're just trying to delay the morbidity and mortality that arises with the lesions that we can see. But there are a lot of reasons in our specialty why people push the indications beyond what's supported by the literature. Some of them are good reasons, some of them are bad. Ultimately, we're not going to know the right thing to do until these trials are done.
I think that's entirely true. And I also think that we have this gravitational pull, both as physicians sometimes and oftentimes the patient, to make the scan look better, or at least make it more ambiguous by radiating every site of disease. But to me, I would be thinking about the potential utility of SABR-COMET 10 approach for, and I agree, 7 lesions is not, in my mind, oligometastatic, but still doesn't mean it wouldn't be potentially helpful. But I'd be thinking of it not primarily to control lesions that may or may not be symptomatic, but rather to debulk disease and ask questions that we have dismissed historically for a very long time, saying that, oh, once the horse is out of the barn, there's no point in local therapy. But step back and ask, well, if you can eradicate all of the visible disease, do you push back the trajectory of the cancer enough that you can have that translate to a survival benefit, not necessarily a cure, but with a systemic therapy for metastatic disease, we're delighted to improve survival by 6 months, even if we're not curing patients. And, so if we could achieve that with SBRT to 6 or 7 lesions, it doesn't need to cure to justify the approach necessarily.
Right. We just have to be clear about our intentions. And there are 2 really interesting hypotheses that are worth considering. One is this old hypothesis, which I think was first put forth in the 1950s, but the earliest paper I could find was about 20 years after that. And that's the Norton-Simon hypothesis. And it talks about efficacy of chemotherapy. And what it boils down to is that as a patient's overall tumor burden in their body increases, the efficacy of chemotherapy is less. And the corollary of that is if you can somehow reduce the tumor burden in the patient's body, let's say from 1 billion cells to 100 million cells or 10 million cells, in theory, the chemo should work better. Not proven, but it's an interesting hypothesis. And maybe that's achievable with stereotactic radiation if it can be done safely. The other hypothesis, of course, is that in some ways, with immunotherapy, we could assist in a patient mounting an immune response. That is a very hot topic. And like most hot topics, sometimes it gets carried a bit too far, where people are now advocating for just treating a single lesion for an abscopal effect with a patient being on immunotherapy. But we don't really have good data to support that. And I worry that that could lead to people going far beyond the data, treating in situations where it might not be helpful. So we need studies to see if this is going to pan out. I have my skepticism about both hypotheses, but I feel like in the next 5 years, we'll have a better handle on whether those are valid or not.
You spend a lot of time formulating the design of trials, especially in this kind of setting. One of the endpoints that is used and has been used historically is progression-free survival in these SBRT trials, and I have been pretty critical of that. I think that
Mhm.
using progression-free survival is really a challenge when you essentially undermine that as an endpoint by eradicating all of the sites most likely to show progression. And, to me, I've likened it to rates of cholecystitis after prophylactic cholecystectomy. It's just
That's right.
so. I
Yes.
have my own viewpoint. And my
Right.
question is, how do you feel as somebody who eats, sleeps, lives, and breathes SBRT trials like this?
So let's first talk about surrogate endpoints in general, and then we'll talk about PFS in stereotactic radiation trials. So surrogate endpoints should only be used if they are a good surrogate for whatever endpoint you really care about. And if the endpoint you really care about is OS, then sometimes PFS is a good surrogate and sometimes it's not. And people have spent their careers looking at how applicable PFS is to ultimate OS gains. Although some people have argued the opposite, and I've heard people say that maybe it doesn't need to be OS. Maybe other things are good enough as they are. Maybe if you can delay time to systemic therapy or if you can improve PFS, that alone is valid. And that's really a decision that comes down to the individual physician and why they want to treat. Because in oncology, we really haven't made a unified decision of what is needed for a benefit. You'll know very well, Jack, when crizotinib came in, it was just a PFS benefit in the New England Journal for first and second line. And aromatase inhibitors were the same way a long, long time ago. But the thought was that the OS benefits would come. I think personally, PFS is worthwhile if you understand the context and if you look at the costs and the quality adjusted life years that go with any benefit. But you're right that the water is muddied in the stereotactic radiation world where you're addressing the lesions most likely to progress. So if you prevent a lesion from going from 3 to 4 centimeters, but that lesion wouldn't cause any symptoms, and that doesn't change the ultimate trajectory of the patient's disease, then it's probably not worthwhile. So we have gone with OS as our main endpoint. So the first COMET trial, it was OS, although it was a randomized phase 2 screening design, so it's a smaller sample size. COMET 10 is an OS endpoint as a primary endpoint. So the best way to get rid of this debate is just aim for OS. If we end up with only a PFS benefit and no OS benefit, then it really gets to be a difficult decision on what to do. I was at your talk, Jack, where you were using appendicitis and appendectomy as the analogy for Dan Gomez's data, and it was a fair result. And I think we are a lot more comfortable now in seeing that that trial has shown an OS benefit, although we know small numbers and that wasn't the primary endpoint. But we need to take it all together. And I think if we're only giving a PFS benefit, we really have to think about what that benefit means. Are we preventing a progression that's going to be a problem, or are we preventing a lesion getting bigger on a scan, but that doesn't change the patient's life at all? It's a latter. If we're not improving somebody's life, then there's no point in doing the stereotactic radiation.
Right. And to be clear, I do think that progression-free survival can be a valuable surrogate, and in the setting of crizotinib or many of the most promising targeted therapies, if we're seeing response rates of 70% and progression-free survivals of 10 to 12 months in settings where we never had anything close to that, I think that that is a different kind of question or scenario than a PFS benefit of 8 weeks. Is that really
Right.
meaningful? So
Right.
in this case, my concern is more around if you're showing lack of progression only and you've eradicated all of the measurable disease previously, that to me is a challenge.
Yeah. And I think there's an interesting dichotomy between PFS in a medical oncology setting versus a stereotactic radiation setting. If you're giving crizotinib, Jack, and you're improving PFS, what we know that's probably happening is that the lesions that we know we see on the scans are being controlled, but we know that it's extremely likely that the lesions that we can't see, the small microscopic deposits, are also being controlled by that crizotinib. In the stereo setting, we know that we're only improving the lesions that we're treating, and all that other microscopic disease is not being addressed. So I think PFS in a setting of a drug, we're more comfortable feeling that you're addressing all locations of the disease in the body, even if some of them you can't see. It's a systemic effect. Whereas in the stereo setting, we know that we're leaving some stuff untouched.
You led and published the SABR-COMET original trial, the 99 patients, and that was Lancet Oncology, correct?
That was the Lancet.
The Lancet, great. What do you think were the take-home conclusions from that, given the encouraging results, but obviously limited size?
Yes. So there are a few take-home messages, and the most important take-home message is that up until the SABR-COMET trial, there was no trial in oligometastatic patients where the primary endpoint was overall survival, comparing any ablative treatment, whether it was surgery, radiation, RFA, versus a palliative treatment. So we really didn't have a pre-specified OS benefit in a trial that gave credence to the oligometastatic state. And what we found in SABR-COMET is that the median overall survival went from 28 to 41 months with the addition of stereotactic radiation to all sites of disease, and the 5-year survival pretty much doubled. And it met the primary endpoint of a randomized phase 2 trial, where it was not meant to be definitive, but meant to provide an initial non-definitive comparison. But in our mind, it's the strongest evidence to date of an oligometastatic state. And the PFS, which we talked about, warts and all, the PFS was doubled from 6 months to 12 months. But the other important finding is around toxicity. Most stereo patients had no toxicity. The grade 2 or higher toxicity rate was about 29%, but there were 3 deaths that were possibly treatment related. And we learned a little bit about how difficult it is to attribute whether a death is related to treatment or not. And I won't get into the details from the trial, it's all in the appendix that we published. But sometimes it's hard to tell exactly what's treatment related or not. If somebody gets short of breath after stereotactic radiation to their chest, and the differential diagnosis includes multiple different things, including radiation pneumonitis, but also maybe heart failure not responding or viral pneumonia. It's very, very hard sometimes to figure these things out. But it does give us pause for a bit of caution when treating multiple lesions. And that led us to lower the doses for the SABR-COMET 10 trial. So the biggest thing I think that's come out of it is it's a bit more evidence in support of the oligometastatic state. The PFS benefit, warts and all, is pretty clear. And it's led to these 2 trials. SABR-COMET 3 is just about to open, and that's for patients with 1 to 3 metastases, phase 3, primary endpoint overall survival. And that's going to be run out of Vancouver. And the reason why they're doing that, Jack, is that in Vancouver, there's a lot more equipoise, and they feel that they can randomize patients on that trial. SABR-COMET 10 is in the 4 to 10 metastases group. That's being run by me. And the primary endpoint there is also overall survival. So really, SABR-COMET has done what a phase 2 trial should do, and it's informed the next generation of phase 3s.
Great. Let's talk about another trial that you were involved with, the one that Daniel Gomez led out of MD Anderson. It's a controversial one. It had small numbers but dramatic effects. And the original publication was in Lancet Oncology a couple of years ago. And then in 2019, updated results with overall survival better in the recipients of local ablative therapy after 3 months of systemic therapy in patients with oligometastatic disease. That trial was terminated early by the Data Safety Monitoring Board based on profound differences in progression-free survival, did show an overall survival difference, but now I would say most people feel that the numbers are too small to make any decisions. You talked about the challenges with equipoise, and I think this issue at the Data Safety Monitoring Board brings that up. We're now needing to do other trials like the ones you're describing, but also the LU-002 trial by Puneeth Iyengar.
Yeah.
To me, it's inelegant, at least, to stop a trial because it's considered unethical to continue to randomize, only to need to open another randomized trial to clarify the situation. What are your thoughts about equipoise, closing trials early, and the need for these subsequent trials?
You've hit on a really good point. So let me leave the equipoise question to second and just talk about what happened in Daniel's trial. Daniel is an outstanding researcher and certainly a huge leader for radiation oncology. And his data safety monitoring board told him that the trial should be closed. And as an investigator, when that happens, you don't have recourse to go back and say, well, no, we have to keep it open. And the Data Safety Monitoring Committee said that because PFS had tripled, that the trial should be stopped. And that could be questioned. And as you've questioned it, I questioned it as well. There are reasons why we have data safety monitoring committees, and that is to protect patients, to close a trial if it's going to be harmful to randomize them. And they can be harmful for one of two ways. One is if you're randomizing them in a trial where you'll never find a benefit and it's going to be futile. And so that would be like a futility analysis, but also if there is clear evidence of efficacy. So the question is, how much efficacy do you need to stop a trial? And I would say that if it's just a surrogate endpoint where what we really care about is overall survival, then the trial should have been continued. Because if it's ethical to randomize patients on LU002, which it is, because many of us are, and it's open all over North America, all over the world, then of course it would have been ethical to continue Dr. Gomez's trial. So ideally, we would have had that trial continued. We don't. And so we have to go with the data that we have. Equipoise is a really important topic in radiation oncology because what happens in any specialty is as you get new, cool, and shiny tools, and as you use them more and more, you as a human being become more attached to them. And we know very well that the more something costs, the more we get attached to it. There's this something called choice supportive bias. And Dan Ariely talks about it in his book, Irrationally Irrational. That's his book.
Yeah.
Choice supportive bias is that after you buy something very expensive, the very next day, you love it way more than you did before you bought it. The more expensive it is, the more you love it. And that goes with our machines in radiation oncology, with our techniques in any medical specialty. And the problem is that as we get using something more and more, we're much less likely to doubt the fact that it works. And that has really come back to hurt us with proton therapy, with new machines in radiation oncology, because you see an arms race. You're on an airplane and you can open the airline magazine and see an ad for CyberKnife saying that it's the best treatment for prostate cancer. There's no evidence of that. And it would be very implausible that that could ever be true. But there's an arms race in these technologies because you have centers competing with each other with advertising based on these things that are unproven. It's very, very difficult. And if we don't, as a specialty, overcome our biases and maintain equipoise, then we won't do the trials to prove what really works. So let's imagine that I had a new technology, Jack, and I think my new machine is going to cure lung cancer. And I can believe that all I want, and I can treat some people with that machine, but I'll never convince you, and I'll never convince the rest of the world unless I do the trials. And we've seen that with protons. If we had done the proton trials 10 years ago, this question would have been answered. But instead, it's been dragging on for all these years. And finally, now the trials are underway. And interestingly enough, the one proton randomized trial we have was for lung cancer. And it didn't even show a hint of a benefit to the protons. I'm not saying protons aren't helpful. They probably are helpful in some scenarios. But unless we maintain our equipoise and randomize patients on trial, then we'll never know for sure. And one of the counter arguments that you hear a lot about is that I have equipoise, but my patients would never agree to be randomized because they would never accept the standard of care. Let's go with a proton analogy. So I have a proton machine. My patient would never accept not having protons. So then you have to ask yourself, well, how do patients know that protons are better? Do they go and do the studies where they irradiate different tissues with protons to see what's better? No, they look at websites. And we had a resident a few years ago go to all the proton websites and rank how evidence-based they were. And they're totally not. Many of them are not, I should say. They have claims on some of them that are not true, that protons reduce side effects, and that's clear. That is not clear. So if we realize that our patients lose equipoise because of us, then we temper how we do our teaching. So what we've done for one of our trials, a new robotic surgery trial that we've just opened, we have a consent video that is a surgeon speaking and then me speaking to try to really give a balanced point of view. But for the sake of our specialty, I think it's very important that we maintain our equipoise and that we randomize patients on trials wherever possible.
I think your points are great. This is not unique to radiation, although I think one of the real challenges also with protons is that so many of the biggest proponents, it's a combination of the academic center but private interests, and very often it's the private for-profit portion that is driving the marketing, which doesn't make it any easier. But that's not unique. I think that there are various private interests in surgery questions and medical oncology, both the testing and the treatments. So, the biggest challenge is just not letting our blind enthusiasm get so far ahead of the data as we promote it, and have the hubris to feel that we don't need the actual data because we just know.
Exactly. That is a perfect summary. We can't let our expectations get ahead of us, and we can't have the hubris to think that we don't need randomized trials.
Well, I'm glad we've solved all this. But this is going to be an ongoing issue. This is a great discussion, and I look forward to continuing this. We'll have, another iteration of this as we get more data and continue the conversation. But in the meantime, thanks so much for taking the time. Great talking to you.
Thanks. I really enjoyed our chat, Jack, and I'll see you at an upcoming conference, I'm sure.
Looking forward to it. Take care. Thanks for listening. The West Wind Podcast is a Beacon Medical Interchange production with sound engineering and distribution by Mark Lindsay of Talking Speaker. We hope you'll be motivated to subscribe, whether at BeaconMedIC.com, through iTunes, or through another podcast service. Please also rate it, and I hope you'll be inclined to tell friends and colleagues in real life and on social media. We're always happy to get your suggestions and other input at westwindpodcast@gmail.com. Talk to you again soon.